can go now.
Good morning. This is Carolyn Jones-Assini, Chair of Ellis Internal Medicine. Welcome to the second Ellis Grand Rounds webinar. We had a great response to last week's Grand Rounds where Dr. Pratt pulled together so many aspects of the COVID-19 epidemic. Then so much more new information has come along. Dr. Pratt kindly agreed and offered to give an additional COVID-19 update. We are offering today a 0.5 CME and 0.5 of ABIM MOC points. To obtain these credits, our audience must send in the evaluation survey for CME and MOC request. The links will be given in this program, or you can contact Amy Semerad. She'll send you the links. Please fill out the surveys. We want to know how we're doing and how this is new mode of transportation of giving you information is working. Our next Grand Rounds will be next week, April 3rd, where we are planning a superb panel of discussion led by Tony Green, our chaplain here at Ellis, and Dr. Jokas Gwenbande and Professor Martin Strasberg. They will be discussing ethical issues associated with limited resources in the pandemic. Our community is so fortunate to have Dr. David Pratt living here amongst us, and even in retirement is so involved with our community's public health. Dr. Pratt is trained in internal medicine, pulmonary and preventive medicine. He is experienced in clinical practice and public health locally, nationally, and internationally. Dr. Pratt served with the U.S. Public Health Service as an epidemic intelligence officer at the CDC. And during his career, he worked on successful smallpox control in India, vaccine preventable diseases at the World Health Organization in Geneva, and in influenza vaccine development with Novartis. He has taught epidemiology at the Clarkson Graduate School in Schenectady and lectures at the SUNY School of Public Health in Albany. A link to this recording of this Grand Rounds will be placed on the Ellis intranet webpage. Dr. Pratt, welcome.
Okay, I just want to get my slides up. Can people see the slides?
Yes.
Okay, I want to get them up into presentation mode. Okay.
And I just want to tell everybody, if you're just joining us now, please put yourself on mute before the presentation so we don't get any feedback.
Okay, so good morning, everybody. Thank you very much for joining us today. We're in the midst of an extraordinary episode in the history, in the annals of public health. Never in human history, in living human history, have we seen an event like the one that's taking place right before us. Overnight, the global totals of individuals affected by the virus has been reported at Johns Hopkins of just over 540,000, with fatalities around 24,000. The schooled epidemiologists across the country will tell you that, in fact, that's probably an undercount of those who have the disease. Only time will tell. So we're going to move on, and I'm going to begin with a big thank you to all the people who are in the front lines of this very difficult effort. We have great admiration for the Chinese, the Koreans, the Iranians, the Italians, the French, the Spanish, the Americans, the people in New York City who are fighting so valiantly against this disease. So tremendous thank you to all of them. Here's my disclosure statement. I have no interest in any of the things that we're going to talk about financially or otherwise. Please keep in mind as we talk today that because of the rapidity with which material is coming into the medical literature, that virtually all of this is not peer reviewed. That is to say, the articles have not been sent out for peers to review and to criticize and make corrections. So you'll be seeing very much almost like dispatches from the field. So please keep that in mind. None of the statements or the numbers or estimates should you take as perfection, only as estimates. So with those caveats in mind, we're going to begin. The objectives of this presentation is to give you a sort of a summary of the nuts and bolts of what's going on, plus a review of the illness itself, what's been going on in the United States with some descriptors from CDC, the Italian experience from investigators in Milan, again, estimates, talk about some of the highlights from what's going on now, progression of the epidemic, management topics that will include the usual things, lockdown, social distancing, hand washing, covering coughs, all the critical stuff, and then some elements about prevention and mitigation. And we will talk about the development of vaccines and the development of antivirals. So nuts and bolts. This number, this infectivity, or R naught, or R sub zero, or the reproductive number, again, looking across the experience in Europe and in Asia and here in the United States, appears to be 2.5, which means that for every individual who is infectious, he or she is likely to infect 2.5 additional people. That's a calculated number, obviously, because we only infect whole numbers, but it appears that when it's calculated over large numbers of population, that's about the number we get to. The incubation period has now been studied fairly carefully. The mean is about 5.1 days. The incubation period usually runs from 2 to 14 days. The attack rate, which is the number of individuals affected from a larger population in the United States, currently is unknown. Remember last week we talked about, and we'll talk about further in this presentation, the likely attack rate for large naive populations, that is susceptible populations, probably will run in the 30 to 40%, which seems like a huge number of individuals who are likely to become infected. We don't know that yet, but that is the postulate from the epidemiologist. Currently, the rate of the attack rate in New York City is around 1.7 per 1,000 population. So there's lots more susceptibles in New York City, and the attack rate likely will go higher, although the measures to lock down and keep the disease at bay is doing a good job. People who are joining, please turn off your camera. Please turn off your microphone as well. Case fatality rates are now calculated to be in the 2 to 3%, which has been fairly robust. You remember that some of this has been higher. Please turn off your cameras. Please turn off your microphones, those of you who are out there. The case fatality rates 2 to 3%. Virus shedding, which is the putting out a virus when an individual is infected, usually runs about 2 weeks, so roughly 14 days. Those of you who are out there, please turn off your cameras if you can. The asymptomatic patients question, are they infectious? And the answer is yes. And I will show you some reports from Germany that underscore that reality. Does social distancing work? And the preliminary, I would offer a preliminary analysis of the data is suggesting yes. I think the Korea experience and the experience in Wuhan underscore that, and I'll show some other information that takes us back to 1918, where you can see that social distancing when the Great Pandemic was very effective in some large American cities. So are the EPI models fully explanatory of what's going on and what's likely to take place? And that answer is no. And the reason is the virus has its own methodology, of course, and susceptibility among individuals changes and the virus mutates. So the EPI models are somewhat explanatory, but not perfectly so. So here's a slide. This was a slide set I developed for a review of the Great Pandemic in 1918. I show this only for two reasons. Number one is I want you to look to the top left, the city of Philadelphia in the autumn of 2018. And you can see those are fatality rates. And it doesn't matter what the actual number of fatalities is. I just want you to look at the difference between Philadelphia and then much further down St. Louis, which is down here. And the reason I want to draw your attention to that is because Philadelphia had a huge parade to raise money for the war effort for World War I. against the advice of the public health authorities of the city of Philadelphia, they went ahead and did a bond parade, only to be followed by a huge outbreak of the great influenza of 1918. You can see down here, St. Louis, which had a lockdown posture toward this, is 5 times less. The mortality rate is 5 times lower. So this would certainly suggest that, in understanding that influenza is a very different disease, but that social distancing, in fact, can have a sharp impact on what happens in terms of the outcome of a respiratory infectious disease like this one, and perhaps the coronavirus as well. Just as a point of interest, during the great epidemic of 1918, there were 7,000 cases in Albany with over 500 deaths, and probably way more than 500 deaths at that time. So very impressive, this great pandemic. The only thing that's sort of been like what we're going through right now, but I wanted to show you this to suggest that things like lockdown, social distancing, and decrease in interaction among people can have a very important impact on outcomes in terms of cases and deaths. This is a chart again from the Great Pandemic of 1918. And I show this because there were 3 important waves of that virus move through the populations around the world. This curve actually is from Great Britain, but it's very similar to what happened in the United States. And you can see on the y-axis here is the deaths per 1,000 people. And so these, if you take a 0 off, you can see the percent. So 2%, 2.5%. Going up the scale. So the mortality rates are really shown here by the height of these curves and the time here on the x-axis. The important thing to see is that there was 3 waves, and some of you have probably heard Dr. Tony Fauci talk on national TV and heard other people speculate. There are 4 research groups have said that the potential is there for the coronavirus to have seasonality. And that is based upon the latitude where the greatest number of cases have occurred during this current outbreak. There were latitudes which had relatively cold and dry winters so far, with less cases in the warmer latitudes. So their postulate based upon that and a number of other things is that we could see, don't know we will, but could see seasonality of the coronavirus as well. Just to recap, remember this is a medium-sized envelope, positive stranded RNA virus that derives its name from those red crown-like things that you see on the top of the virus. Those are actually called S or spike proteins. That's going to be important when we talk about vaccine in the coming slides. So remember that this, and we'll show you a little bit of better picture of this virus in just a second, but this S protein is very important in terms of thinking about how we might fight this with a vaccine. It's also probably the major way that we build immunity against this virus as well. The main route of transmission, remember, is these sneezes and coughs, a large number of particulates. Largely, these are droplets. When the air is very dry, they shrink and become aerosols. Some of the data you'll see in a bit here are about aerosols, but this mostly what happens when we sneeze are these droplets. They're moist. They fall rapidly to the ground. Aerosols can be more airborne, and when we model that, we see numbers that suggest they stay in the environment longer. And here's the data. Some of you have heard about surfaces and have had some anxiety about this. This was a letter that was posted to the New England Journal of Medicine the 17th of March, and it was a very thoroughly done, well done study, but because of the fact there was no time for peer review, it was published as a letter as opposed to a full article. And what the investigators showed is that when aerosols, and they created aerosols in the laboratory and let the virus come from the aerosol and measured how long they could capture virus particles in the air, up to 3 hours. On copper surfaces, it was 4 hours because copper, as you know, has some antibacterial properties. On cardboard, a day, and then on steel surfaces like countertops or plastic countertops, as much as 3 days. So these are theoretic limits. If you actually look at their data, you can see that the number of virions or virus particles falls exponentially with time. And also I make a note here that although they looked at aerosols, most of what we cough are droplets and moist particles, not dry aerosols. Here, just one more look at this virus, and I draw it to your attention because I wanted you to make sure you see these S or spike proteins here, and reiterate the fact that there is a lipid membrane that goes around the RNA that's inside this virion capsule. The reason I reiterate the lipid nature is because this is why soap and water are so good, so powerful against this. The lipid membrane becomes permeable to the soap and water, and the virion particle splits, breaks open, and is no longer able to infect people. Last time we talked about the way viruses like this take over. They hack into our systems, our genetic systems inside our cells. This would be a respiratory epithelial cell on our nose or throat. The virus makes entrance by connecting with an ACE2 receptor, and then makes its way in, takes over the reproductive mechanism of both genetic material and proteins, creates more virions, more particles, and over here on the right-hand side, number 6, you can see the mature daughter virion popping into a space, and this might be the respiratory tract, or it might be a joining cell, or it could be the bloodstream. But this is how the virus comes in, replicates itself, makes daughter cells, copies, and then bursts out into either the airway or an adjoining tissues. Just a quick word about testing. We've all heard a ton about testing. The main test that is done in laboratories around the country is a reverse transcriptase PCR test, which is somewhat laborious. There are now cassettes and multiple tests can be run at once in the big labs, but it's kind of one by one. So it's really fairly time consuming. And as you know, the turnaround time has been very frustrating to clinicians, and understandably so. Recently approved under an emergency use authorization from the U.S. Food and Drug Administration, an express test has been built by Cepheid, California company that they have, again, cassettes. They can process very rapidly, about 45 minutes from the specimen being put into one of their cassettes until the answer appears on the computer. Several antibody tests, and we talked about this last time. Wouldn't it be nice if we had an antibody test so we could do seroprevalence studies to know who in a population has been affected? Several of them have been put in front of the FDA. None have been fully approved as of yesterday, but there's hope that we're going to get one of those tests, and they probably will function at point of care, at the bedside, or in a clinical laboratory in a hospital with a drop of serum or blood, whole blood perhaps, and it would be somewhat like a pregnancy test. You'd see bands of identity for IgG and IgM to tell you whether you've had an acute or recent infection with the coronavirus. What we know is that since the world population is supposed to be naive, if you have zones of identity for either of those immunoglobulins, you're likely to have had the disease almost certainly recently. So I wanted to recap the terms that we've used before, and we already talked a little bit about the attack rate, and I defined it. We talked also about the R0, the number of people who get infected after contacting with someone who's ill. We talked about the case fatality rates, and remember we said they're in that kind of 2 to 3%, probably, maybe a little lower if we get lucky. And we also said that when the grid analysis from the H1N1 so-called Spanish flu or the great influenza, when that came through, again, case fatality rates were in that approximately 2% range, maybe a bit more. The epicurve we've talked about, which shows us the number of cases represented on the y-axis and time on the x-axis. This is the curve that we're trying to flatten. We're trying to keep the peak of this curve, that is the number of cases over a short period of time, as small as we can in order to decrease the burden on healthcare systems, equipment, PPE, ventilators, ICU beds, ambulances, police and fire, and so forth. The incubation period we've talked about. Herd immunity, remember, is the immunity that is conferred by groups of people surrounding people who are naive. Remember, the example we gave previously was measles in a classroom of children. If 99% of the kids in the classroom have immunity to measles through vaccine, and one child with an immunodeficiency is in the classroom, it is very unlikely that wild virus in the community could come into that classroom and get to that naive child, because transmission is blocked by the herd, quote unquote, of other children in the classroom and protects that individual who is naive. Remember, the name of the virus, when you read about it in the literature, is SARS-CoV-2, which is the same virus we're talking about with COVID-19. Remember, we said that this particular virus is about twice as infectious as seasonal influenza and about 10 times more deadly. Keep that in mind. Control measures we've talked about in the past. Here's an X to say that containment is unfortunately something that's no longer possible for us. As you know, this disease, this virus is widespread throughout the United States, most of Europe, and large areas of Southeast Asia and Asia. Blunting the impact of the virus and the illness is what mitigation is about. And recently there have been papers from the UK and elsewhere, this one from the Imperial College Response Team, suggesting that even more stringent measures that they call suppression, which tries to reverse the growth of the epidemic, reduce the case burden, and pushing the numbers to low levels, maintain this situation for a long period of time, which they postulate is where we need to go. As you all know, we're currently in a struggle and a discussion at the national level about how much of this clamp down, lockdown we can afford from an economic basis. The models produced by the epidemiologists suggest that suppression, which is very tight, is the way that we're going to save the most lives. This debate is going to go on for a long time. Here are just three representations of a do-nothing curve, a mitigation curve, and a suppression curve. The modelers, suppression is going to give us the greatest opportunity to bring down the exponential growth across large populations. So how do we then decrease the R0, or the reproductive number? And here we just see in the upper left a look at the R0 of Ebola, which was 2, and SARS, the original SARS, which was 4. So what we want to do is we want to interrupt that transmission between the little red people here to break that chain of transmission and to decrease the R0. Remember, you may remember this, that when the R0 drops below 1, the transmission of disease ceases. It stops. So measures like quarantine, lockdown, closing schools have a huge impact. The school theory, which is a great inconvenience for many of you parents that are listening today, has to do with the fact that children are probably more likely to be asymptomatic carriers and bring the virus into the household, affecting parents and grandparents. So the school theory has to do not so much with the children themselves, but the children as vectors of this virus in larger populations. Remember, the dream is to have a vaccine, because when we think about herd immunity, the two major ways that we reduce transmission from a viral infection is, number one, a large number of people who are convalescent, who have had the virus and now have immunity, and plus the people who have a vaccine that is effective and potent. Currently, we don't have a vaccine available. Social distancing, we all know about keeping 2 meters apart. Hand washing and sanitizing of hands and surfaces, very important. Deep cleaning of areas where there might be residual virions sitting on counters, so forth, or on whatever. I would remind people that the mode of transmission is largely respiratory, and you have to remember that viruses are obligate parasites in living cells, so they can't reproduce. They can't increase the copy number if they are not inside a living cell hacking into the reproductive system, the genetic systems. So although it can occur and be on surfaces, the way it really causes havoc is by being in living things. So keeping surfaces clean, keeping your hands clean, covering your coughs, and contacting fewer susceptibles over time are effective strategies. If you look again on the left, there's the epi curve, and you notice that what we're trying to do is push down. Point number 2, push down, flatten that epi curve. Now the question is the area under the curve smaller if we push it down? And I think that remains to be seen. Our dream is that we could not only push down the surge or the peak, that giant peak that Governor Cuomo talks about in his broadcast. If we can drop that peak, perhaps we can also reduce the area under the curve, which is the total burden of disease. That is not known. We're going to have to see where that all goes. So we're going to look at the situation in the United States. There's Dr. Fauci, who is one of my heroes, a terrific researcher and a spokesman for how we deal with this disease. This data is preliminary. It's from the Centers for Disease Control, and it just shows some of the pattern of what's been going on in the United States. And you can see these are cases per day. They've marched steadily up through the 16th of March. No surprise there. This also gives an idea about hospitalization, ICU admissions, and deaths. And I would only draw your attention to the very big spike here of the 65 to 75-year-old people with a number of hospitalizations. So they appear to be sicker in this series of cases. They are occupying more ICU beds, and they are also having a fairly substantial case fatality rate. Not as high as those who are over 85, and this certainly has been the experience in Italy. We're going to talk about that in a bit. This is just a summary slide, and if you look at the bottom, you see the total number of cases that were analyzed by CDC were 2,500 roughly, and they saw a hospitalization rate which is actually quite a bit higher than what we've talked about in earlier broadcasts. In earlier broadcasts, we postulated that there would be about 15% of affected individuals would need hospitalization. This data suggests it's a bit higher than that. The ICU admissions, remember, we think is going to be in the 5% range. This is slightly higher, and the case fatality rates is right in the range that we've talked about earlier in this broadcast. Here's again a model, and on the left-hand side is the total population in that triangle. And we said the attack rate might be 30 to 40%. And when you look at that 30 to 40%, what you see is that probably as many as 82% will have mild illness, serious illness in the teens, 14, 15, 16. ICU admissions here would be in the range of 5%. And then finally, mortality, which is going to be, would be in the very tippity top, which remember we said was about 2%. So we're going to talk some more about the emerging clinical picture of when we see these individuals as they show up. Perhaps to some of your surprise, and certainly some of my surprise, that as many as 15% of the patients who have the illness are asymptomatic, which is a large number. Certainly kids fall into this bucket pretty much, but also adults. And this was largely from the Diamond Princess work. They did work based upon the transmission on the cruise ship, the Diamond Princess. They were able to look at the number of oncoming cases and how they presented once they were swabbed, and we had the PCR data. Looked like a lot of them, 15% were asymptomatic. We've now learned also that mild cases may appear more like colds or simple URIs with a sore throat, runny nose, kind of pediatric coryza pattern, if you will. But the majority present with fever, cough, frequently with fatigue and muscle aches, and ultimately going on to shortness of breath and the more troublesome clinical picture that you're aware of. This is simply the evidence for transmission of individuals who are asymptomatic from Germany, and I showed you the Diamond Princess data, which underscores this very important fact. Other clinical caveats that are worth keeping in mind is the plain radiographs may be unimpressive when these patients present, and we've talked about the 5%, the 2%, and the 1% who need ventilators, as you've heard Governor Cuomo talk about. The time on ventilators is surprisingly long. In China was as much as 17 to 18 days. And unfortunately, the mortality of people on assisted ventilation was very high in China, about 50%. And the longer on assisted ventilation, largely the worse the outcomes. The people who died in Wuhan had as many as 22 days in intensive care, much of that on assisted ventilation. So not to be too grim about this, but once people, especially the elderly, wind up in assisted ventilation, it becomes very tricky. Now we're going to go on to Italy, and I think many of you have listened to and seen documentation from Italy. This is a collected series that was based upon case finding and case definition, WHO, not necessarily all culture positive. The area of Lombardy, which is the general region in northern Italy, is outlined here in pale blue. You can see the cases have been falling as we get to later in the month. By the 8th and 9th of March, cases are beginning to fall. Remember, they had finally very strict lockdown and social distancing and reduction in interaction among people, but it took a while, and they had a huge surge of cases. These are just maps, and if you look in the upper left, sorry, that's an analog clock behind me. If you look in the upper left, you see cases on the 15th of January, and the lower right, you see what happened by the 5th of March. So you can see how this spread in dramatic fashion throughout the Lombardy region of Italy. Remember, this is the economic engine of Italy, very powerful area for both manufacturing and other things in Italy, including the city of Milan. This chart, I think, is important and interesting because if you look in the lower right to Lombardy, you can see that the effective reproductive rate, here called the RT, which is the net reproductive rate, goes from relatively low numbers and it gradually picks up until it peaks and goes down. That's why the mean reproductive rate turns out to be 2.5 or something like that, but it can actually accelerate. And when the mass of people with viral infections gets great, infectivity appears to get even bigger than our simple estimate. So the R0 or the RT, which is the net reproductive rate, you can see it's sort of a moving target. And that's why what we represent is usually a mean or an average over long periods of time. Interesting looking about viral loading. This particular chart comes from the Lombardy region. Once again, it shows that the burden, the virus burden in asymptomatic and symptomatic individuals appears almost the same. So very interesting. That's why the asymptomatic patients are so troublesome. They have very high viral loads, as high as people who are symptomatic, and can cause us problems if we don't keep them under control. This is why testing is so important. Testing and case tracing and isolation, which are the tenets of basic public health, would be so valuable if we had sufficient testing. We're going to get it eventually, but right now we're sort of still behind, even though we hear a lot about the availability of testing, we're still behind. A strategy of ascertainment, case tracing, isolation would help dramatically. And this is an example of why that makes so much sense. This is just a summary of the Lombardy cases. Remember, these are by case definition, not necessarily by PCR. And there's the numbers here are a little bit interesting. I think some of you may have heard Dr. Burke's, Debbie Burke's talk on TV about the male-female disparity, 2 to 1 in the Italian data. In New York State, we've already been looking at that, and we do not nearly find a male predominance as great. Dismaying is the rate of affected healthcare workers in Lombardy. As many as 10% of the cases were among healthcare workers. The age distribution you can see here. This is different than what we're seeing, and it's not age adjusted for the population. Hospitalizations much higher than what we talked about earlier, and ICU admissions much higher than we talked about earlier. So the Italian data may be skewed. It's going to be a while before we really know, but The male-female ratio discrepancy 2-to-1 that Dr. Burks talked about, just wanted to show you where that data came from. Remember, reducing R0, the transmissibility of this virus is everybody's job. So social distancing, stay inside, remain calm, wash your hands, sanitize surfaces, cover your cough. If you're sick, wear a mask if you can get one, I guess. Limiting travel is critical, and clean and disinfect surfaces. There are a number of the websites will show you what you can use to clean surfaces. Remember, ultraviolet radiation inside of sunlight is a very potent element, or very potent thing that can help kill this virus. So on the horizon, is there light? Well, maybe. A number of these drugs that I show here have either been tried or been talked about, and you notice the method of action goes all the way from chloroquine, which we believe is a polymerase inhibitor for heme, down to remdesivir, which is getting a lot of popular play right now in the literature, which is a nucleotide analog. It blocks polymerase. Some of this is familiar to those of you who treat HIV patients. Some of these mechanisms and even some of these drugs you are probably using in your practice as well. Right now, the WHO has announced that there's going to be a large solidarity trial, a mega trial with these 4 particular agents, remdesivir, which we talked about earlier. Remdesivir has been used in China. Remdesivir was used for the treatment of the index case in the state of Washington. A 35-year-old Asian American man who did well, was in the intensive care unit. I think he was on assisted ventilation, but ultimately did well. You've heard people talk about hydroxychloroquine and chloroquine, which, as some of you know, are both used in rheumatoid arthritis and also in malarial prophylaxis and malarial treatment. And ritonavir combination with interferon. Those are the 4 drugs that are going to be used. And the chart on the right shows you the method of action or the mode of action of each of those agents. And so one has to be hopeful that we will get some activity from these drugs, 1 or more, hopefully. We know that remdesivir and hydroxy and chloroquine in vitro are very active against the virus, but it's a long way from a test tube, to our own physiology. Now, a word about vaccine development. This photograph, I think, appeared in all the news services, United Press and Reuters. A woman who volunteered to be one of the subjects in the phase 1 trial of this vaccine that is currently being piloted by the NIH, and this is being done. This particular part of the trial is being done in Seattle at Kaiser. And this is the vaccine trial that is being done is with a very interesting RNA-based segment of the genome from the virus that codes for the spike or S protein. And so simply stated, what really goes on is there's an encapsulated piece of messenger RNA carrying the code for that spike protein. It enters into our immune system. Vaccine is put into our muscle. It goes to the regional nodes. The antigen is presented to our immune system, and we begin to build antibodies against the spike protein. So it's as if we are building our own vaccine using our own immune cells as this piece of RNA is replicated, and we build the antibody against it. So a very interesting way of thinking about vaccine development, not like what we have done before with either attenuated viruses or killed viruses or adjuvanted viruses. This is virus portions. This is a very clever way of doing this. We will see. Remember, phase 1 is only to look at can we tolerate this? Are there untoward reactions? Do people get ill with it? And then is it immunogenic in humans at all? And from there you go to phase 2. This vaccine is being given at day 1 and day 28. Titers of antibody are tested before the second dose is given and then after that second dose. And then they're followed for 6 months with repeated testings and titering. So I'm going to close with this from Martin Luther King, that we're all tied together in a single garment of maybe immunity or destiny caught in an inescapable network of mutuality, where really all of mankind is in this enterprise together. And we have to keep that in mind as we think about what we might do to help the people who are helping the individuals who are ill, and what we might do to help each other. So please remember, for those of you who are frontline healthcare workers, self-care is critical. Taking care of yourself, getting adequate nutrition, some time off, breathing time for exercise, vitally important. So please do that. So I'm going to conclude there, and we'll take questions. Oh, good. So it was 40 minutes, not quite 30, but 40.
Hi, if you have any questions, please type them into the chat box and I'll read them to Dr. Pratt for you. Also, we're asking that you complete the evaluation. The evaluation is, I'm going to read the web address for those of you that are on the phone. The web address is bit.ly, so bit.ly/327 DOIM. Again, that's bit.ly/327 DOIM. Okay, so I'm not seeing any questions so far. We'll give it a couple minutes just to make sure.
Dr. Farber, I don't see where the chat box is.
Okay, go ahead and ask your question, Dr. Farber.
So I just want to clarify the mechanism of the vaccine. So we're actually taking that mRNA, translating it, and then taking the S protein, sticking it on our cell surfaces or releasing it into the serum where it becomes hopefully antigenic.
Yeah, so what is going to happen is that we're presenting to our immune system this, the mRNA goes into our cells. The S protein is then created in our immune system, in our cells, and presented to the immune system. So we build antibody to the spike protein. So we're each cycle, we're building more antibody to spike protein, IgG, IgM. Also, the innate system is probably active as well. So the mechanism is, since we're using our own cells to build the antigen, which our immune system begins to build antibodies against. Am I making that clear?
Yeah, I think I've got it. And initially, when I heard about it, it was very weird because I thought that the vaccine was asking us to build antibodies to the mRNA, which wouldn't be exposed to our immune system.
Exactly.
Normal infections, but
Exactly.
This makes more sense. Thanks.
Yeah, sure. And if you want to, the Moderna site, they have a very nice sort of explanation of how this works. There's a lot of proprietary information, because what we have learned from vaccine development with mRNA vaccines is that if you just try to put it in without encapsulating it or protecting it, it's just completely destroyed, by our cells and by dendritic. It doesn't even get to the dendritic cells. It's it's just destroyed by our innate mechanisms. Another question?
We had one come in over Dr. Jones's phone. Dr. Jones, you want to read that?
Yes, the question had to do with the seasonality of this virus. And if there is such a thing, then why would places like Singapore, Australia, which are, opposite to our season, they're still having a major problem. So what does that tell us, that maybe there's not a seasonality?
Well, first of all, that's a very good point. And, again, remember we said at the top of the hour, do the models perfectly explain what's going on? The answer is, of course, no. Two things. Number one, what we know from influenza activity is that in the equatorial latitudes, we have year-round transmission of influenza, low level, but it goes year round. What we know is that in the temperate latitudes, both south and north, we tend to have seasonality we tend to have transmission when the relative humidity and ambient moisture in the air falls, and we get more aerosols. So the theory of the case is that we'll have more transmission in the temperate latitudes and less in the ongoing low level in the equatorial latitudes. The details about the modeling require, I think, more than a grain of salt. So I don't know that we can accurately predict whether there will be seasonality, but the desire, of course, to drive the R naught as low as possible now would certainly help making sure that there's not going to be a whole lot of virus to move around when winter then comes, when the cooler weather comes. If the hypothesis is correct, with summer coming to the latitudes where we now see the big outbreaks, it should attenuate the outbreaks. We should get a reduction in the number of the R naught and the number of cases. That's the theory. And there are 4 independent models that we use to begin to look at this, and they all seem to agree that seasonality was at least a good possibility. There's no guarantee of any of this stuff, but it looks like seasonality could occur.
Okay, Dr. Jones has a follow-up for that.
No, a second question. The second question has to do with the issue of the whole population wearing masks. And of course, we've witnessed that happening in the Asian countries where everybody's in a mask. Healthcare workers, everybody walking on the street is in a mask. And at the same time, we know we have a shortage of the surgical masks. So people are making masks and making their own, and sometimes putting vacuum filters in them, within the mask. But I'm just trying to think, have you come across any recommendations, any suggestions about what maybe we should be moving, or it's not that much helpful in doing something like this?
The position is a good question. Position of the CDC is that for people who are well, that using the masks cannot be supported by evidence. We certainly know that anybody who's symptomatic, no matter what they've got, anything that looks like a URI here now at this time and place, putting a mask on them makes a lot of sense, because we could, it might reduce some of that transmission. You saw that 40,000 particle sneeze that I showed earlier. If you could reduce some of that, it would make sense. We've got an issue with supply availability. We need to make sure the frontline healthcare workers have got all the masks that they need. So making your own mask may have some utility. There's simply no data. We simply don't know the answers to many of those questions. The theory is, if you've got a cough or cold, you definitely want a mask. Otherwise, CDC says it's hard to justify putting everybody in masks, and certainly there aren't enough masks available. Other questions?
This one's coming from Trish Ford. Since there is contagiousness in asymptomatic exposed people, does it make sense for healthcare workers to not be masked when providing patient care, since it's not socially distant?
That's a great question, Trish. I certainly think that, depending upon, I'm reminded of how pediatricians function when they think there may be a measles case that somebody wants to come into their office. They immediately try to put them into a quarantine area where they're away from the rest of the patients. I think we ought to do, healthcare people who are seeing folks who present with respiratory infections, number one, should try to move that person aside in their ambulatory clinic. Number two, make sure that person has a mask on. Number three, when you interview that individual, the amount of distance that you can keep between you and the patient is valuable. Beyond that, then you begin to listen to the chest and you do some of these other things. Ideally, with gloves on and appropriate gowns. Very tricky to do. I think the better strategy is when people think they've got something that's presenting like a mild coronavirus is to self-quarantine and stay home. Don't come to the provider's office where you could potentially contaminate other patients and the providers too. So, but following the advice and the guidance of pediatricians, I think here would be very valuable if people do come to the outpatient setting.
Okay, our next question is from Dr. Finch. He asks, how does the population density of Lombardy compare to New York City?
Oh, not even close. You know, there are 4 cities. Milan hasn't had that many cases, but the three cities that I showed you are reasonable sized cities, but nowhere near the density of New York City, making the problem in New York City much more acute, much more dangerous.
Dr. Petrillo has a comment. He says a big thank you to Dr. Pratt for taking his time to educate us and inform us. And then Dr. Yap has what I think is a question. He says 3 scenarios on home quarantine. The first is a positive test. What's the duration of quarantine, and does the patient need to retest?
Yeah, I mean, initially, first of all, John Petrillo, thanks. Thanks for the plug. Dr. Yap, I think the original recommendation was that people on home quarantine should be 14 days or when they're no longer symptomatic and no longer have fever. And then after the end of fever, 72 hours after that. And in situations like in the state of Washington, they were actually requesting, if they were positive in the first place, and if they're home quarantine because they were positive, 2 negative swabs. If you're just home self-quarantining because of contact or you don't feel well, ideally it'd be nice to get tested to find out if you really did have it and then follow the general guidelines. We think that people who are free of fever and are a week or so away from their last symptomatic episode can wear a mask and begin to really interact with us. We know this carriage that goes on later. In fact, there's at least some data that suggests from the onset of symptoms until the last amount of virus that can be captured with swabbing is probably almost a month, so roughly 26 days. So there's a lot of potential carriage that can go on. So ideally, if we could measure them, if we could test them again quickly, that would be ideal. I think right now CDC says symptom-free for a week and then free without fever for 72 hours should be okay. But please go to the CDC website. This is changing all the time, so please go to the CDC website for the final word on that.
Okay, I think you answered the other 2 parts of his questions, so we're going to move on to the next question. After massive self-quarantine, combined with those who were ill, do we know or think what will happen when folks start moving around again?
Yeah, well, what we hope is that we break transmission. We drop the R0 below 1 and the virus can not find a home or as many homes. The models suggest that we may have sporadic disease because we will still have many people who are naive, that is not immune in the population. Even if the attack rate is 40%, that means you have 60% of people who will remain, susceptible. So that if we can get the R0 down with suppression and all the measures we talked about and reduce it so that we're not seeing new cases similar to what's going on in Wuhan, then I think you can begin to repopulate our shops and stores and bars and restaurants and whatever, and then with careful surveillance. But again, you can put in place more testing, more quarantine, and more aggressive standard public health measures, even if you begin to have sporadic cases. We know.
Dr. Pratt, your volume just left us.
Can you hear me now?
I can hear you now. Yeah, you may need to repeat that answer.
Okay. So what we know is that there can be persistence in spread President Wilson went to negotiate the Treaty of Versailles in the summer of 1919, he became ill with the pandemic strain of the great influenza virus. So sporadic cases can continue to echo in populations, but we believe if the major transmission is reduced or truncated, that it'll be much more manageable for our public health professionals to deal with it. Other questions?
Our final question is from Nicole Dewey. She asks what the validity of the test is.
That's a very good question. This is a question that epidemiologists struggle with all the time. It's really a question of sensitivity and specificity. When we have a true positive, how much can we trust it? When we have a specificity, a true negative, a negative, can we believe that? The way the testing is done in the laboratory is that they have known positives and known negatives that go into the cassettes that they put through the machines. And if the test does not accurately find the positives and the negatives, then the test is ruled to be invalid and must be run again. But the question is, how would we validate that test without another test? You'd really need two tests to be able to run one against the other. So right now, that's a great question. I think all we can do is rely on the laboratory experts to tell us that their true positives in their analysis are coming up to be true. Their true negatives are coming up to be true as well. And we base evidence on that. Ideally, it would be nice to have testing that would look to put one against the other to test the validity of the individual test. This question about sensitivity and specificity of the testing has come up in chats that I do with other people interested in public health. And right now, it's some head scratching. We will have other kinds of tests, and I think we'll be able to run one test against the other to try to check for sensitivity, specificity, validity, and positive predictive value and negative predictive value as well.
Okay, we had a couple of comments and another question come in. Dean Lemary wants you to know that it was another outstanding talk.
Thanks, Dean.
Dr. Yap would like to know, do you need to wait a few days from contact before getting the test?
It's a great question because he's really thinking in terms of reproductive numbers and infectivity, and also how quickly we get copies of the virus. Probably reasonable, although what we know is that people have good sized viral loads even before they're symptomatic. So that if people have had an exposure and they have anything like runny nose or mild cough and so forth, if the availability of the test there, it would be nice to know what your status really is.
Okay, one final comment from Dr. Farber, and then I'm going to turn it over to Dr. Jones-Assini. He says, thank you for your time and expertise. I think the herd threshold for SARS-CoV-2 should be 55%, not 45% on your slide.
Oh, that was from last week. Thank you. We've had a number of corrections. It shows that even early in the morning, people can still do math. So Marty, thanks. We really appreciate that. And you're absolutely right. That was the issue on herd immunity threshold calculation, 1 minus 1 over R naught. Thank you, Marty.
This is Carolyn Jones-Assini. Thank you. What a wonderful audience this is. We are really, truly all paying attention, which is fantastic. I again want to remind you, complete your survey if you want to get the CME credit. And even if you don't want CME, please complete the survey because it helps us so much in understanding how well this is coming across to you in this new form that we have. And next week, we are planning a grand rounds where Dr. Joka Squenbande, Professor Martin Strasberg, and Tony Green will be leading a panel on ethical issues associated with limited resources in this pandemic era. So again, thank you so much for being with us.
And I just put the link in the comments again for the evaluation form. Just click on it and it should take you right out to the evaluation form. Thank you.